you better finish within 2 hours. If it's not removed promptly, it may start sepsis.
I don't think there will be many plastic surgeons who will be happy to harvest the jejunal flap themselves.
Every microsurgery is important to the patient. Tell the young surgeons how to make it safe.
Hello everybody, welcome to another episode of The Rest is Plastics, with me your host James Chan.
And me, Anton Fries.
Today we have a very special guest. We have Professor Hung Chi Chen, who is the Superintendent and Professor of Plastic Surgery at the China Medical University Hospital in Taiwan. And Professor Chen is one of the most prolific microsurgeons around the world, particularly for super complex cases. He's been going since the 1980s, and as we talk to him today, he was still in the middle of an OR session doing a free ALT flap on a complex limb reconstruction case.
We spoke to him about his paper, Postoperative Monitoring of Free Jejunal Flaps, a composite clinical scoring system based on a 40-year institutional series and a systematic review.
It's a wonderful episode, and I'm sure you're going to enjoy it.
Professor Chen, welcome to The Rest is Plastics. We're honoured to have you here with us. So we're going to discuss your paper regarding the post-op monitoring of free jejunal flaps, a composite clinical scoring system based on your own 40-year series, but also a systematic review that you've done to monitor free jejunal flaps. So if I may, the first question then, can you perhaps tell us what was it that inspired you to choose this as a topic to write about?
This could be traced back to 1980. Professor Nahai, he was invited to Taiwan at that time, and he told me many things important. He said that in 1959, Dr. Zeidenberg started to do jejunal flap transfer, and he said, Professor Nahai said there are many pitfalls in the free jejunal flap transfer, because there are two things. One is that jejunal is always buried inside the wound, so you cannot see very clearly, not like other skin flap. The second thing is that jejunal flap has a very short time of tolerance for ischemia because it has high metabolic rate. Once the pedicle is divided, it starts autolysis. If you cannot finish the revascularization within 2 hours or 3 hours, it will become irreversible. So this can be dangerous for the flap. And Professor Nahai told me that he was working in Emory, which is a private university, and he had to let every resident do part of the surgery, and every resident commit one mistake. So altogether, there are a lot of mistakes. Although he could salvage the flap finally, but some of the flaps still get lost. So it's not like a LT flap, not like skin flap. The skin flap always can be done by the resident, and the ischemia tolerance is very high, like 4 hours. But jejunal flap, you better finish within 2 hours. Also, it's difficult to monitor. That's why I think I should write this article to tell the young surgeons how to make it safe. Because although jejunal flap has been done a long time ago, but many plastic surgeons still hesitate to do it. They prefer to do the skin flap. For example, after total pharyngolaryngectomy, they used to do LT flap, and the resident can do it easily. But there is disadvantage of skin flap. One is that the skin flap can become strictured after radiotherapy. Many of the patients need radiotherapy after surgery. So after surgery, there will be sloughing of the part of the skin and become strictured, especially at the junction between cervical and the thoracic esophagus. That's the narrowest point of the whole esophagus. So, but on the other hand, a free jejunal flap can tolerate radiotherapy. The reason is that although the mucosa may slough off after radiotherapy, But if you supply with glutamate, the mucosa cell will regenerate within 2 weeks. There will be no stricture, especially at the junction between the cervical and the thoracic esophagus. This is very important for the patients having a long-term result without stricture. So I like jejunal more than skin flap for the reconstruction of esophagus. But for other cases like the patients with kidney transplant or immunocompromised patients, I still use skin flap. But then we have to be very careful in follow-up. And that's the reason I want to write this article telling the young surgeons how to monitor quickly, monitor accurately, because we need to catch up the time for re-exploration. After you close the wound, the jejunal flap is a floppy tissue. It may get kinked. The vessel can get kinked, especially after swelling, and even during the surgery, the artery may have spasm. It's different from the skin flap, so we have to be very careful. And so I think the article will be useful for the young surgeons.
Absolutely. Thank you very much for that. The time critical nature, as you said, is absolutely key. One is to get the anastomosis going so that you can get it plumbed in within 2 hours. But also, I think people hesitate to do the jejunal flap because if there's any problems, they need to be able to get the patients back into the OR as soon as possible. And sometimes logistically, that's quite difficult. So going to your study, you've got an interesting combination of your experience as a single center cohort study, but also a systematic review married up to it. Can you tell us about the methodology?
Usually, I think the monitor loop shares the same blood supply as the main segment. So you can have direct observation of 4 things. One is peristalsis. You can tick on the monitor loop and see if there is peristalsis. Number 2 is secretion, because you have one end open of the monitor loop, so you can always see the secretion. If there is a sanguineous or bloody secretion, then it means that there is venous congestion, so you should open directly. And the number 3 is the color of the serosa. But serosa color can change with time. So initially it's pink, but finally it becomes pale gray color. So the color may not be very accurate. And number 4 is the puncture. If you are not sure, all these things you are not sure, you can puncture with a needle. And if the bleeding is brisk with fresh blood, it means that artery and vein both are patent. But if there is congestion, the punctured blood is dusky. So you can tell directly from the monitor loop. But you cannot give puncture to the main segment, because if you puncture, it may cause mucosa coming out and there will be a fistula. So we can puncture on the monitor loop, but you cannot puncture on the main segment for reconstruction.
But just to be clear, the monitoring loop that you're talking about is done after you've done the microvascular anastomosis, and then you exteriorize a short segment through the cervical incision. Is that right?
Yes. I think you can have direct observation and have a prompt reaction to re-explore if necessary.
Okay, and so the monitoring is quite intensive, isn't it? I'm just reading your paper, and it says that they are in the intensive care setting for 2 to 3 days, and it's every 30 minutes.
And then the nurse can tell us, and they can send the pictures to us, so we can have close communication. If necessary, they can do puncture, but usually we don't like puncture. But if necessary, they can do puncture. Of course, we also have the Doppler as a help to check the blood supply. But Doppler only can tell the artery; it doesn't tell the vein. The vein, you need to observe from the secretion of the monitor loop. If there is a hemorrhage or sanguineous fluid coming out from the monitor loop, then it must be the venous congestion.
And the Doppler you're talking about is the external Doppler.
Oh, yeah, Doppler.
So you don't use any of the implantable machines that go
No.
around the pen?
Yeah, because we have, but it's more expensive, and the patient have to pay 20,000 NT for that monitor.
So I guess that's obviously the methodology of the surgery, but in terms of your paper, how did you structure that?
We have we grade the observation. For example, we have peristalsis, we have four grade, and secretion we also have four grade, and color we also have 4 grade, and pinprick bleeding also 4 grade. Altogether there are 12 points. If it's less than 2 points, then it's minor, we can observe. But if it's less than 5, then we still can observe. But after 5, the consultant should be called and then come to watch if there is anything wrong. So they can have a quick reaction to explore, because ischemia tolerance is short, so they have to be quick. That's why I think monitor loop is useful.
For our listeners, what were the main results that you found in your study?
I think we want to have a high sensitivity, but the specificity can be low. The sensitivity is 100%. There is no we didn't lose detection, but specificity we have 76%. That means some of the false positive can be normal, but that's okay. Re-exploration is better than losing a flap.
Yeah, I think every microsurgeon listening to this talk will agree with you, Professor.
Because we need to be careful. Every surgery every microsurgery is important to the patient. For example, I tell you that one of my fellow in the other country, he failed twice the jejunal flap. I think he didn't have a good monitor, and finally I told him to do a pedicle colon for reconstruction, but he could not do it, so the patient died. So I think that jejunal flap, if there is necrosis, it may start sepsis if it's not removed promptly. A lot of problem after necrosis of the intestine. It may start local sepsis or systemic sepsis. And if there is local sepsis, it's difficult to repair with other methods. So that's why jejunal flap is not welcome in many centers. Many plastic surgeons still hesitate to do it. I think this article is important for the young surgeons.
Yeah, that is, the head and neck microsurgery is high stakes in all cases, but even higher, I think, in this situation. Wow. Okay.
Jejunum is more sensitive to ischemia more than colon, because colon can tolerate, the colon has a lower metabolic rate. So it's not so difficult, but jejunum you need to be very accurate and react promptly if there is anything wrong.
So you obviously have a huge series and a huge experience. I think 351 cases.
I want to tell you the reason. Here in this country, we have many patients of corrosive injury. When people have a problem with wife or with the husband, they commit to suicide with a corrosive agent. And then so we need to do jejunal flap. And the second is that we have a lot of people chewing the bitter nut. And the bitter nut causes hypopharyngeal cancer or esophageal cancer. So we do a lot of jejunal flap. And the third category is patients referred from the chest surgeon, because chest surgeon cannot do micro, so they refer to us if there is a segment shortage of esophagus, then we do it for them. So 3 categories of jejunal flap transfer. That's why we have a lot.
Wow. Yeah. I mean, that is certainly more than our experience. And I just wondered then, you did your review. How could you compare the findings from your review to your own experience?
Oh, I think that all the we have more than 10 papers. They talk about how to detect the blood supply of the jejunal flap. But I think the monitor loop is the best. It tells you everything of the main segment. If you are worried, then you apparently monitor loop is the best one to monitor. And I want to tell you something which maybe you should not show in this talk, because in this country, I am a general surgeon as well, so I harvest the jejunum by myself. But in other countries, if you want to harvest jejunum, it relies on general surgeon, and the general surgeons, they're good, but they sometimes not very careful about the pedicle. Their main job is to remove segment of jejunum, but they don't care about the reconstruction, anastomosis. So I've seen a case in other countries. They take the first jejunal flap, it failed. So because the vessels were cauterized, so they take the second one also cauterized, because jejunal pedicle is not really very long. So they throw it away. Finally, they do the free forearm flap. So I think for the reason of safety, maybe I recommend the plastic surgeon harvest the flap on your own, but you can ask the general surgeon to close the wound. I'm not sure if they agree or not, but this is the best way to do a jejunal flap safely.
I don't think there will be many plastic surgeons who will be happy to harvest the jejunal flap themselves.
Yeah.
But can I ask you a little bit more about your surgical technique? So for the listeners who can't see the diagram in your paper, the monitoring segment is a section of the jejunal flap based on the same mesenteric blood supply, and then that short section is exteriorized through the incision in the neck. So there's a short section of jejunum outside of the skin. So that in essence is a sentinel flap for what's going on inside. How long do you keep that exteriorized segment for, and do you just clip it and take it away after a few weeks? What happens?
Yeah, if you don't need any more, you can remove. But sometimes, I tell you, we divide the jejunal flap into 3 segments. The second one is for coverage. We remove the mucosa. It becomes a cerebromuscular flap to wrap around the location of location is very between the cervical and the thoracic esophagus. That makes it much safer than just a single anastomosis between jejunum and the thoracic esophagus. And the third loop can be used as a monitor loop. And if you don't need, you can remove. But if in case there is any leak, you can use that segment to repair, to augment the anastomotic site.
So you're talking about the intestinal anastomosis between the cervical esophagus and the rest of the GI tract. I see. Okay. But typically for the exteriorized segment, the monitoring segment, is that something that you need to take them back to the OR to do, or is it something you can do?
You can ligate and remove it at bedside, because the patient in our country don't like to be operated twice. And so
Right.
we remove it at bedside.
Oh, I see. Okay. And then you can stitch up the skin at the bedside as well.
One thing to be careful is that because the monitor loop shares the same blood supply as the main segment, so you need to be careful to position the mesentery carefully, instead of kinking, because you may get kinking if you are not careful. So place the mesentery in the proper position so there is no kinking, and the monitor loop can be a safe monitor for the main segment.
And how do you monitor for leakage?
Oh, you mean leakage? I think we are very careful. We have 2 NG tubes going through the pharynx and through the junction between cervical and the thoracic esophagus. So there will be no ankylosis between anterior and posterior wall. And we used to suture very carefully, especially the junction between cervical and thoracic esophagus. So it's important to prevent leakage. If there is leakage, the patient may postpone the schedule of chemotherapy or radiotherapy. And two NG tubes can keep the junction free of ankylosis. I think it's important. Also, one of the tube can decompress the air because the patient may cough, especially old patients may cough a lot after surgery. So the two tubes can guarantee there is no air pressure inside the lumen because there are many holes. And before the patient start to eat, we do the esophagogram to make sure there is no leakage.
Great. So moving on to your sort of conclusions and what lessons we can learn, I guess, I mean, you know, it's amazing, this 41-year, I mean, I thought I'd miscounted, but, you know, this 41-year experience of doing this operation, how do you do it? You must have evolved it, I'm sure, in lots of subtle ways, but what are the biggest changes between how you do a free jejunum in 2025 versus 1984?
Oh, I will thank Professor Forden Lahai very much because I listened to his advice before I started. So there is very little change of the principles. He told me a lot of his secret. So I think I want to write this and let people know how to do it correctly.
So what are some of these secrets then?
Oh, I think I put this on the paper. Also, I have many other articles talking about jejunal flap, like how to do the jejunal flap for the lubrication in the dry mouth patients, and how do you compare this with the colon flap. I think I wrote a lot about intestinal flaps. I like the intestinal flap.
You mentioned at the beginning that you prefer skin flaps in immunocompromised patients. Can you tell us why that is the case?
Because, for example, if the patient has a liver transplant before, then I hesitate to open the abdomen again. That's why I do the. If the patient has previous trouble with the abdominal surgery, then I still use the skin flap. Otherwise, I always prefer intra-abdominal organs.
Makes sense. And then the other thing, I've had the pleasure of going to some of your talks at meetings over the years, and I know you've shown some amazing results with speech using intestinal flaps. And yet I also think from some papers people publish that the ALTs can be better. Well, why do you think that is?
ALT, the advantage of ALT is that the voice tube is more rigid, so the pitch is higher. But in the ALT flap, there is no natural valve to prevent regurgitation of saliva or food into the airway. So I think I still prefer to use a iliocolon flap because a iliocolon flap has a natural valve. Also, you can, during the surgery, you can check the competence of the ileocecal valve. If it's incompetent, you can detect with a spray of water through the colon side. About 20% of all patients may have incompetence. Then you narrow down the ileocecal valve. And if you want to get a better result, I think ileocecal valve is the key. And the second is that you can just take a very short segment of ileum, but the rest of the voice tube, you can use a DP flap to replace. Then it combines the advantage of ALT flap and iliocolon flap. Then you get a better voice, high pitch, and no regurgitation.
I've got one more question about the results, which is that it's amazing how many you've done. It's probably one of the most in a series worldwide. And the flap survival of 97.7% is incredible. I'm just wondering, for the ones where the flap cannot be salvaged, What was your next reconstructive option for these people?
If it's not salvageable, I will throw it away and do another jejunal flap.
Okay.
If the patient has no other problem, the second jejunal flap is still better than a skin flap in terms of long-term result. It has a natural secretion, so the patient doesn't need to use the hand to help swallowing. But if you use skin flap, the patients may sometimes need to use a hand. And also, if you use a skin flap for both esophagus and voice, then there may be accumulation of secretions from the sweat gland or sebaceous gland or sweat gland, and that will obstruct the voice tube. So I still like to use the intestinal flap.
Professor, this has been wonderful. Thank you so much for your time. I know it's late in the evening in Taiwan, and you're still operating, which is an inspiration to us all. I know our listeners are going to love listening to this talk. So thank you so much for joining us.
Thank you very much.
James, that was a fascinating discussion with one of the real doyens of our specialty. What were your main takeaways?
Well, first of all, that he's been doing jejunal flaps for over 40 years. To me, that's insane. And to have the flap success rate to be, in the 97 percentile, which is crazy to me. And so what strikes me, well, first of all, the technical competency from day one, but also the setup, to be able to have that really intense monitoring and the facility to go back into theatre to re-explore and salvage the cases.
Yeah, likewise. And I thought I'd miscounted when I was figuring out how long you've been doing it for. It was just phenomenal. And and I think, we use all the expensive adjuncts to do our flap monitoring. And, he actually has a scoring system, which is, as he said, 100% sensitive, clearly not entirely specific, but that's the right way around, isn't it, when you're trying to save these flaps. But there's definitely a logistic burden of that kind of intense clinical monitoring, which is probably, or maybe as expensive as any of the technical wizardry we try and use. So that would be an interesting comparison.
Yeah, I think it really emphasizes the importance of just good old clinical acumen, and also having a dedicated staff post-operatively. I think many units will have a dedicated bay on a ward, or if they're lucky, like they have in China Medical Hospital, where they have an intensive care unit specifically for free flaps. I know they have the same. You and I were there in Chang'an, in Linkou, Taiwan, and they have a similar thing. So monitoring of flaps is such a difficult thing sometimes, particularly for muscle flaps, and jejunal flaps must be even more difficult.
Absolutely. So yeah, it was it was a tour de force, and really enjoyed speaking to him. So.
And for all the secrets on jejunal flaps, you've got to read the papers.
Read his papers.
He wasn't divulging anything.
He's not just going to give it up on a podcast.
That's right.
Well, James, it's great as always. And until the next time, please like, subscribe, leave us a review, and remember,
the rest is plastics. Cheers, Anton.